Hello, and welcome to the BCN and Friends podcast, where we have real conversations about learning, leadership, and the lived experiences of nurses and healthcare professionals across the emergency spectrum. Each episode, we sit down with thought leaders, BCN certification holders, and industry experts who share their stories, their insights, and the challenges that shape their work. Our mission is simple: to amplify the voices of those making a difference every day, because your experiences drive progress, inspire others, and shape the future of nursing. We're here to honor that in every episode. Sometimes funny, sometimes serious, and always valuable. This is BCN and Friends, and we're so glad you're here.
In this episode, we're joined by three exceptional trauma-certified nurse leaders for an in-depth roundtable discussion. Trauma nursing lives at the intersection of standards, systems, and bedside decision-making. And in part one, we explore regulatory expectations, performance improvement, trauma program structure, and gaps across the trauma care continuum. This episode is titled TCRN Roundtable, Code Red Activated, Part 1.
I'm Holly Briggs, a professional development specialist at BCN and one of your hosts for today. I'm joined by my co-host, Michael Dexter, our Director of Professional Development. Hi, Michael.
Hello, Holly.
It's great to have you with us. And in this episode, we're joined by three incredible guests for a two-part Trauma Certified Registered Nurse, TCRN, Roundtable. Together, we'll explore all things trauma, from national and state standards to the continuum of care, performance improvement, quality initiatives, and beyond. This is one of those conversations where the expertise is deep and the direction is wide open. And I have a feeling it's going to be a great ride. Michael, would you mind introducing us to our BCN friends, Merideth, Ashley, and Jamin?
Yeah, absolutely. I will introduce each one of them. I'll start with Meredith. Meredith Gradowski is an experienced nurse leader with over 15 years in the field and a strong focus on trauma care. She holds a BSN from Arizona State University and a master's degree in nursing administration from Queen's University of Charlotte. Currently serving as a trauma program manager, she leads system development and quality initiatives to improve patient outcomes. She is especially passionate about advancing pediatric trauma care within adult trauma centers. Then we have Ashley Metcalf. Ashley began her nursing career in the emergency department and has spent more than 20 years dedicated to trauma care. She currently serves as a trauma program performance improvement coordinator at a level 1 trauma center where she focuses on advancing quality and outcomes. Ashley is also the president of the Trauma Association of South Carolina and co-chairs the Advanced Trauma Care for Nurses Committee through the Society of Trauma Nurses. She brings both deep clinical experience and strong leadership to the trauma nursing community. And then finally, we have Jamin Rankin. Jamin is a dynamic nursing leader with experience spanning emergencies. That includes trauma and air medical care. He currently serves as a trauma program manager and stroke program manager at Ochsner LSU Health, where he leads accreditation, education, and system-wide quality initiatives. His background includes frontline work as a flight nurse and emergency clinician in both rural and level 1 trauma settings. Jamin is widely recognized for his leadership and contributions to trauma systems, earning honors such as ENA's 20 under 40 and BCEN's Distinguished TCRN designation. Welcome to the BCN and Friends podcast. It's a pleasure to have each of you with us today.
Thank you.
Thank you
We're
so much.
glad to be here. Thanks for having us.
I know that Michael only captured a very brief part of each one of you's bios. We could honestly spend time just talking about kind of your experience, both in clinical and in leadership. We could definitely spend a long time doing that. Unfortunately, I've given you guys a lot of questions and we've got a lot of questions to cover, so we can't spend too much time there. But I do want to ask that each one of you holds leadership roles now. But you've all worked at the bedside, and really now from your perspective, what standards or expectations apply directly to bedside trauma nurses that a lot of TCRNs and those thinking about taking the TCRN exam, they don't even understand actually apply to that role. So, from your view now, looking kind of into what is that clinical role, where do you see the tie-in between those standards and expectations and that frontline role? So I'm going to start off. Let's hand it off to Meredith, but I want all you guys to weigh in.
Yeah, there's a few standards that definitely apply to the bedside nurse, but one that I think isn't talked about maybe as broadly as normal in the trauma community is that the bedside nurses need to understand that every intervention or procedure, we need a time captured for that. So the trauma registrars who are abstracting the data, they're abstracting the time lac repair is done. They're abstracting the time the patient goes to imaging. And those are all quality metrics that are reviewed by the trauma program, part of PI. So I think the bedside nurses need to know that's why we harp so hard on documentation, just because we need those granular times for procedures.
Awesome. What about you, Ashley? Where do you think some of that falls?
Well, I think even just to back up like one step, I think a lot of people know that there are trauma centers, but they don't know the difference between like a trauma center and just a non-trauma center. And so like there are specific standards that come out either by the state American College of Surgeons or at the state level that you have to follow. And those standards just give the trauma program a chance to show how well we take care of the patient. And a lot of those you just have to qualify. And so like Meredith was talking, a lot of times you have to show reports to show how well you do a certain standard. And there's like a huge long list of standards. But a lot of times the standards have to do with timeliness. So we have to capture and show that orthopedics respond timely to severe orthopedic injuries. So the time that they were called and then the time that they responded. The same for interventional radiology. I know that that is something that a lot of trauma centers look at is we have a patient who needs timely intervention. And so the time from intervention that we have to report on standards is the time that we consulted or put the order into IR to when the arterial puncture is. And that's 1 hour. So we've got to be thinking constantly, like, what is your next step? What are we preparing the patient for next and helping to move towards that? Because you guys know in trauma resuscitation, an hour can fly by.
Yeah, 100%. And I think what you're saying too is just being those proactive clinicians, those proactive providers to where even from the time like a call comes in and you understand like the mechanism of injury that you're capturing that thought and then you're putting it in your documentation. And I love how Ashley you tied it in with Meredith because documentation is so huge and it's such a I hate to say burden, but sometimes it feels that way. All right, Jamin, what do you got?
Yeah, I will just kind of come off exactly of what they both said and talk about a specific one where our nurses may feel overwhelmed and like we are constantly putting more on them. But when we talk about things like mental health screenings and alcohol abuse screenings, those are standards that are written very distinctly in the American College of Surgeons, and most states follow very closely to what the American College of Surgeons has. And at times you can feel like you're always just asking your nurses to do more. You're asking them to do another screening. You're asking them to make sure you get this done. And hopefully we get to the place where they don't just click through them because there's real research and there's real benefit to looking at these. But I can see where it's important for our trauma nurses to know that if we're asking you to do a mental health screening, if we're asking you to do an alcohol abuse screening, or if it leads toward working toward an intervention, there's real reason behind it, and those are accrediting standards that we're trying to live up to. It's not just another task to add on to a nurse who may already feel very busy and stretched very thin. And just like she said, we have to run reports. There's a percentage of patients that we must meet this has to be done. And it's as leaders in the trauma world who sit in front of reviewers for verification, we have to explain why we can't meet a metric if there's a number. And there's a lot that goes into that, working with each department leader to make sure that we understand that these screenings are a part of a bigger picture, not just trying to task someone to death in whatever unit they're working with, because these don't just happen in the emergency department. These move a lot of times throughout the patient's day.
And to follow up on that, not to sound negative towards it, but to follow up on that, I've heard a lot of pushback from staff over the years that say, well, we're just doing this because some regulatory body says we have to. Like, how do you get people to really be engaged in the fact that there's a patient value to this? It's not just a standard that we're trying to hit, even though, yes, we need to meet the numbers and we need to show competency and validate what we're doing as a trauma center, but how do you get them engaged in the actual process of this is important to the patient?
Well, me personally, everyone who's screened the little old grandma who they thought was the sweetest lady on the planet, and when they actually did an alcohol abuse screening, and she maybe, has a little more alcohol intake than they anticipated, and understand that sometimes just following the rubric, asking the questions, get you to a place, and then when you offer them an intervention, it may be the first time someone's actually intervened and said, no judgment. We just want to know that there are opportunities for you. There's literature behind it. There's a lot of research from especially the social work case management side that do a lot of work with these patients. But what about the nurses that haven't seen that, right? What about the nurses that haven't had that experience? I think sharing stories, showing your personal in-depth facility metrics to show this is the number, these are the number of patients we've screened, this is the number of patients who screened positive, and when we offered intervention, actually this number of patients accepted. And these are patients who may have never before been offered an opportunity to work through something, something they're having an issue with, or maybe it's a moment that they realize they have something they need to work on. And it really does have great benefit. If you've done this job for any amount of time, you will review patients and be surprised at patients who are more open to opportunity than you realize. And I would love to hear Meredith and Ashley give any feedback from this, because we refer to it a lot of times as expert, but this alcohol screening can be a thorn in our side sometimes when people either want to just click through it or don't actually complete it in a timely manner and document it. Not just do it, but document it so that we can actually see that it happened.
Yeah, I think back to Michael's question, how do you teach people that it's not just a regulatory box to check? I would say data sharing. It could be story sharing, but also, if you're looking at a particular, metric that you're trying to improve, you're going to want to collect that data and share that data. As many committees that are willing to, hear you out. I'm sure a lot of people on this panel attend a lot of committee meetings and share a lot of data, but sharing outcome data is how we gain buy-in from the bedside nurses.
And I think the big story is just like your why. So in the trauma program, we'll refer to standard 5.2 or like name the standard. And we know that it's in there. But when we're trying to translate it into our bedside clinicians, of just telling them why is this important, that for alcohol screening, that we have a lot of patients who come back into our trauma program recidivism because of continued alcohol use. And so how can we help to support the patient as a whole and to continue to grow our trauma program? And there's oftentimes great evidence-based practice behind these standards, and that's why they're there. So just sharing the why. This isn't just a checkbox, but there is a why to help our patients with this.
Yeah. Absolutely. Well, great responses. I appreciate it. And, just moving on from there, you talked about standards. I know all three of you probably have the 2022, 2025 optimal care of the injured patient standards gray book memorized by heart, with every single point and subpoint. But, getting into that and the standards, there are, state verification standards, there are national standards from the American College of Surgeons. And so when we look at some of those variances between, ACS trauma centers, state trauma centers, and then trying to determine how to kind of meld those two together into a trauma program. And then some people feel like the whole conversation of NCLEX world versus real world, and this is documentation world versus real world, and we're all in here trying to save a life. We're not trying to do all these standards, and some of those kind of things that we hear. So how do you again, I know some of this goes back to data sharing and things, but as more of a trauma program side of it, how do you get it to where you, as a trauma program manager or somebody that's in the data and the performance improvement side of it, how do you get it to meld appropriately within your state to say, these are the standards from ACS, these are the standards from my state, and this is how we're trying to appropriately meet all of these so that we can be a verified or a designated trauma center? Jamin, starting with you.
Yeah, so in our state of Louisiana, here our state accepts the American College of Standards as the standard for a trauma center. So if you meet the standard of the ACS, you meet the standard of the state, which is great because there's no additional, but each state is different. And that's a great thing because it gives some states the ability to mold standards or expectations based off of where they live, maybe differences in there. But one of the things that I kind of want to talk about, we talk about kind of tension between the two. And to me, I'd say when we talk about standard and workflow, it comes down to diversion. And so diversion is a word that a lot of people in emergency departments and different places hear. And a lot of times your emergency department feels at capacity and it feels full and there's a lot of patients and you feel like your resources are maxed out. And then all of a sudden, you're still have trauma patients coming to you, even if your emergency department is deemed to be on diversion. And that gets to be, especially for our nurses working, like taking care of the patients, they feel overwhelmed. Like, what do you mean we're on diversion, but we're still taking? The American College of Standards kind of specifically takes over and says to go diversion for trauma, you have to do this. And that may be different from what your individual hospital has determined as being ED diversion versus trauma diversion. And so we have to kind of walk that line between we have to report hours of diversion, we have to report reasons for diversion, we have to report when we went on diversion for trauma, when we came off, and we have to report that to our regulatory body with trauma every time we get verified or re-verified or visited by the ACS. And I can really see tension between what do you mean we're telling you we're at capacity, but you're still anticipating that trauma patients come to you. And it's a difficult task to be able to try to work with your teams to help understand that the goal is to try to maximize resource for the sickest patient. And when you're a trauma center, you've been picked out of the group of hospitals in your state and your region to say, you've got your flag up, you're ready to take trauma patients when the other facilities may not have the same flag. And I've heard before, like, well, they have a surgeon and they have an operating room, but they don't have the things in place and have to live up to the expectations that trauma centers have to. And so whenever you're being verified by a regulatory body who's expecting you to keep your flag up unless certain criteria are met, and whenever the ED may feel burdened with a whole bunch of other patients, but you are still trying to take trauma patients in it. Very similar with stroke, it's a very similar idea. But when you're talking about the trauma patients, your regulatory bodies are expecting you to only go and turn away trauma patients with a specific set of criteria. And that to me is one place where you get some tension between what a regulatory body is doing and sometimes what you're saying. And I haven't even mentioned if you have a state trauma system like we have in our state, they may have some other variants in that too. And a lot of times they're the ones routing the patients to you, even if you say you're on ED diversion, but not trauma diversion. And I'll let my friends talk about it more and discuss if they've seen similar things. But in my personal opinion, if I talk about where some of that gets a little bit rubbing against the flow, it's when we have to talk about diversion and trauma.
Yeah, well, I think that's a great example, Jamin. I'm sure both Ashley and Meredith don't know what diversion is. I think that's really only state specific to Louisiana, but we'll just go out on a limb and try. Ashley, over on the East Coast, if you want to jump onto the diversion topic, or you have any other conversation related to the state and national requirements for ACS.
Well, I'll just tell you my initial thought process when Jamin said diversion. I was like, diverting drugs? What? So, no, we are level 1 in South Carolina, and just because of our geographics, we truly do not go on diversion very often at all for trauma. It would only been, I think, a couple of hours that I've been on diversion in my, 14 years with the system. And it's because of like a system failure. So that we don't do diversion a lot, but it's one of those things that exactly like you're talking about, Jamin, we do go on diversion for other things, but for trauma, I think everybody just has it in their head. We know that we have the resources and that we have proven that we take exceptional care of these patients, and they need to come here to get the care that they get. And a lot of it's just geographical as well.
Yeah, diversion isn't in our vocabulary here. I mean, it might have been a while ago, but yeah, we're almost never on trauma diversion. But that also has to do with our geographic location as well. I mean, I'm in Arizona, and Arizona has many trauma centers, and so there's just really never a reason that the patient can't, get to a trauma center that's ready to receive them. Um, but I did think of an example about kind of some tension between regulatory requirements and real world workflow. And that is sometimes our facility has a hard time accepting transfers from non-designated trauma centers coming to the ER. So sort of on the diversion kind of topic, but when our ERs are full and, exploding at the seams, we don't go on diversion for trauma because from a trauma service standpoint, we're ready to receive and treat them. We have all the capabilities, but some of our ER partners get frustrated that maybe patients being transferred in can't be direct admits, and explaining to them that we have criteria where the trauma team needs to see these patients, and they will be coming through the ER. So I think that's another kind of tension that's sort of on the ER overcapacity topic, but it just goes back to explaining to them like the differences almost between a trauma center and a non-trauma center. You may not have a trauma qualified physician evaluating that patient at a non-designated trauma center. So you want to make sure workup's complete and done as fast as possible.
Yeah. Well, it sounds like all of the conversation is it's very interesting because my background is in the emergency department. So I understand diversion. Not that I got to do it a lot because it's similar mindset that, hey, we may not have the space, but we definitely have a doctor or two and maybe a nurse somewhere. So this idea of diversion was always very interesting because as a bedside nurse you could feel almost like that overwhelming, like there's just so much care that needs to be done, there's so many patients that need to be seen, this is just it, we're going to come to a grinding halt. And then you would get a call like, hey, you have a transfer coming in. You're like, where are we going to put them? The roof? And so and the idea is you'll find space. And working in the outside of a leadership role, I didn't always understand that. Once I kind of grew into like a charge nurse role and educator supervisor, like you began to see that ultimately this patient needs to be where they can get the care that they need, right? And so unfortunately for you, that was your hospital. That was your emergency department. Like that's where they needed to be. And I love the kind of flexibility, that ability to pivot in those situations where you're like, that patient shows up and in your mind, you're like, I guess we're gonna put you next to this. Like, you know what I mean? You're just like trying to figure it out. But then realizing when you catch hold of their eyes and you look at them and you realize like this patient looks at us and sees us as the solution to a problem that they're facing, which is super scary, then I don't know, there was something about like, okay, we're okay, let's figure it out. Let's do it. Let's figure out how we can get them to a place where, the trauma team or whoever can just come and see them and, we'll get them out of the hallway soon. And it was tying that humanity back. And sometimes it felt like when you got that initial call, like you couldn't picture that person. But then like once you saw them, it was like, okay, let's figure out how we can give you what you need. You came here for something. Let's see what we can do to meet that. So I do understand it still didn't always lessen the tension. There were definitely times where I was like, the only thing that's going to fix this shift is a Diet Coke and like 5 minutes on the ramp. That's where we're going to need our coping to kick in. So, but I did want to kind of talk about this idea. So actually, every single person on this call holds the TCRN, myself and Michael included. And so that being said, I already told you my background has kind of, mainly been in emergency. And you guys all, again, we kind of talked about your bios. We kind of all span a little bit of what I call like the spectrum of care for a patient. And so with that in mind, when people are taking the TCRN or thinking about taking it, there's this idea that trauma certified registered nurse, when everybody hears trauma, they immediately think initial injury. Like, I don't know, like it's just like, blood, guts, gore, like that's what people think about. And while that's not wrong, it doesn't really encompass the entirety of trauma care, which everyone on this call I think understands. But I want to kind of dive into that a little bit. So thinking about that, where are the gaps that you believe that TCRNs and those trauma nurses should be more aware of? And I'm actually going to ask Michael to kind of weigh in first, just from kind of a certification standpoint. But then, like I said, all of you are TCRNs, all of you are involved in trauma care in different ways and have come through different paths. But where did you see gaps and where do you see gaps still? So, Michael, what about you? Let's start off.
Well, this is a deep subject, and you certainly have put me out on the spot by asking me first. I will tell you my thought on patient care has really changed over the last, I would say 10 years or so. When I started out in EMS, and you see a very small window of a patient's injury. And then I was in the emergency room, and you see another window, you see another stage in their journey. And I heard an interesting presentation a few years ago that stuck with me, and it was a physician talking about the difference between being cured and being healed. And being cured is really focusing on fixing the problem, and being healed is really more holistic. And I think even if you like put trauma care aside, I have a big passion for cardiac care. If you look at people that end up in shock, cardiogenic shock, hypovolemic shock from trauma, things like that, and you look at their long-term mortality, 5, 10 years out, even the people that do well in the hospital, they go home, they recover, they still have a higher mortality than the people that never had that happen to them because the entire body is impacted. So when we talk about things emergency related, like coup contra coup injuries, we often think of the brain, but we don't think of the fact that the liver and the kidneys and multiple other organs had the similar injury pattern that happened to them. But we kind of hyper focused on one of the ABCD initiatives just to make sure that the patient was stable and okay. And I think when we look at the spectrum of trauma care, to me, obviously, one of the biggest things that we could impact is not having them become a trauma patient. But once they are, and we've done more things and advocated more for things that can prevent injury, or even, different legislative things that can help reduce injury, then I think one of the bigger things that we should focus on holistically with the trauma patient is follow-up care. I think that there are many, many times in medicine when in the premise of trying to make the patient feel better, we undersell them on the need for rehabilitation and follow-up care. And I think there's a number of excellent physicians out there that I have heard over the years that have told patients, oh, you'll be fine, just a couple weeks down, you'll be back to work. And they're not wrong from the procedural side, but I think that oftentimes they're wrong from the healing side, and they're not truly healed of what their problem is. They might be cured, they might be able to move an arm or an extremity again, but they don't have the full capacity to do what they used to be able to do. And some of them never regain that. And I think that getting back to that component of trauma care is very underemphasized in the nursing world. So I think from a perspective of the TCRN certification, that getting people to realize that aspect of it is extremely valuable to the overall long-term care of the patient. So that's my very short answer on where I think those things stand. But I think that people often find patients are better after hospitalization and after discharge, but that doesn't really mean mentally, physically where they need to be. They just might not be at a point where they need to be in the hospital.
That's why I started off with him. You know what I mean, guys? I knew that he was going to weigh in pretty heavy hitting in the beginning. And so with that answer, who wants to follow up, tag in on that?
Yeah. Who wants to follow Michael Dexter giving you a full rundown? I'll just start out since I started talking. I 100% agree with what Michael said. We put a lot of focus on the initial assessment, initial treatment, and even getting someone discharged from the hospital or wherever we have them if we send them to rehab. But, as a program, we don't have a lot of standards to follow and see what their 30 and 60, 90-day outcomes are. And is there support that can be given? At times, people, and I think Ashley and Meredith probably agree with me, we feel overwhelmed trying to keep up with the acute side and the initial side and tracking and trending all of those things. But if you look at hospital systems and trauma centers as a whole, there's a real big opportunity there to ensure that completeness of care that's more than just getting someone fixed, but actually ensure that they are truly healed and have the resource they need. So Michael did a great job of talking about it. I will add my 2 cents to the question that you asked and the what could we cover? And I was just reviewing the certification outline, and the end there's like 15 questions, and one little part of it is EMTALA and its verification and credentialing, like ensuring that you understand regulatory expectations of the trauma center. And I think that part of the TCRN that could be really a part of the focus is that if you are a TCRN working at a trauma center, you are going to have to live up to regulatory expectations. But also, if you are a TCRN working at a non-trauma center, if you understand expectations of trauma systems and regulatory bodies, it could also help you understand the flow of patients. I think Meredith brought up the idea of transfers and understanding the way that trauma transfers, especially for the acutely ill patient, having that basis of how those things should work in a system and within a trauma system and a trauma center, that could be beneficial to a trauma certified registered nurse who understands not just the acute assessment and care, even all the way through rehab, but what does it mean as far as being a part of a system, and what does it mean for the regulatory body that may be certifying my hospital, is what my job as the trauma nurse mean?
Great answer.
Yes, I completely agree. Kind of, I'll go, Jamin, following you. I think one of the things that's different about the TCRN, if you look compared to some of the other certifications, whether it's CEN, CPEN, there is the clinical aspects. And I think studying for your TCRN just helps you dive deep into the clinical aspects to kind of even learn more into the pathophysiology and the why. But just as Jamin mentioned, there is a whole aspect of trauma care that is away from the bedside, and everybody that plays a role into the trauma system and trauma care. I remember the first time walking around the ICU, but my injury prevention coordinator was with us. And so I was introducing her to some of the ICU nurses, and the ICU was like, we have somebody that prevents injury. Don't we want patients? Don't we need patients? And they didn't understand it. But I think that kind of goes back to, Michael, what you were saying is that we're truly trying to see that the best care for the patient is for them to never be involved in the trauma. And so that is why ACS and larger trauma systems have started focusing on the injury prevention aspect and looking and getting us to ask these PTSD questions, these SBIRT questions, because that is looking at things bigger than just the clinical care during the patient's initial trauma stage, is looking at them as a whole and definitely incorporating PTSD. So I do think we're getting better and we're recognizing the long-term effects of trauma, but then also just trying to get them not in to begin with. So those regulatory questions, they really do make a difference and impact clinical care, but they're different than the other certification exam questions that you'll see.
I mean, everything to everyone's statements. I agree full-heartedly. I do agree, we don't, from a trauma system standpoint, we don't have a great, 30, 60, 90-day follow-up process. I know ACS released a pilot program to, reach out to those patients 30, 60, 90 days out. I don't know that we've seen the results from that pilot study, but I think in the future it will come for trauma centers. I'm just not sure, how they'll operationalize that. And then as far as kind of gaps that, someone interested in a TCRN exam or becoming a TCRN, I think really understanding kind of what happens to the patient after that acute, after the ER, essentially, their whole hospital stay is acute care phase, but understanding all the things that play into trauma care after that first 12 hours, essentially, is important for the TCRN to understand. Also, the injury prevention programs that the trauma centers may have, but if you're interested in taking the TCRN exam and you work at maybe a level 4, talk to that program coordinator or manager and figure out, what they're looking at. I think that would be, invaluable for someone who's interested in understanding what they may not see at the bedside.
Thank you guys. That perfectly rounds out and actually just slides me right into this next question that we're going into, which has to do. Okay, so we hear PI constantly. We hear this performance improvement. And truthfully, the first time I ever heard this as a nurse, I was like, what? Did not understand it. I honestly, we were still, I'm dating myself now in nursing age because at that point we were still paper charting. I know. Yay. Ah, the dinosaur has left the room. That being said, we were still paper charting, and I was like, somebody's looking at this. And so, that tells you a lot. So computerized charting has obviously made a lot of work a little bit easier, I would say, in some ways, but also now there's just a lot of emphasis in things. But that being said, I guess performance improvement, what does that actually mean in practical terms? And then I'm also going to ask for you guys to share an example of maybe how strong, or it could be how very weak documentation has changed the course of PI and the review of it. So, Ashley, why don't you kick us off?
That is a great question. And until I actually saw the job posting for my job, I had no idea that PI existed. I had no idea what it was. I worked in the emergency department and we did the paper charting. It was beautiful. There was like a body you could draw circles on exactly where it was. It was great. I knew where everything was. Muscle memory kicked in great. So I knew that we'd get feedback on our documentation. I knew that we had a trauma committee, but truly understanding that there was a trauma program. And Meredith talked about their registrars before and like data points, that every trauma center has a trauma registry that collects data on the patient from the time they get injured to whatever their final disposition is. I had no idea. I didn't. And so when I first started my job, this role was new to the system as well. And so when we were like, okay, what does this look like? What do we do? We felt that we were great if the last case that came in the night before our meeting went well. If the last case before the meeting was awful, then, oh my gosh, everything is awful. It stinks. But then starting to evolve and learn more about standards and National Trauma Dictionary and TQIP, Trauma Quality Improvement Program, it's actually looking at data to see where you're standing. So somebody may think, hey, we rock this. We are out of the park. But you pull a report from the trauma registry and you're like, oh, but we truly have an opportunity. Or someone may have an awful case and they're like, oh my gosh, this is awful. And you're like, that was just a one-off. That one case is a one-off. If we look back past 2 years, this is actually how well we are doing. So it is looking at how can we improve using data to identify where your opportunities are. One of the cool things I love about PI is trauma systems have to do it. It's in our ACS standards, your verification designation standards. But the cool thing is that it impacts many different things in many different systems. And when you see a trauma program grow, you will see the whole entire system grow and improve because it definitely impacts care across all patient populations. It's not like the clinicians are like, oh, this is a trauma patient, so I'm going to do this. But, oh, wait, I've got a non-trauma patient. And all of those great things that I learned and have realized impact the patient, I'm going to throw it out the window. That doesn't happen. They continue to have those standards and that high level of care for all patients. So trauma care doesn't just benefit. It's the whole patient population that benefits. And then talking about documentation. Yeah. Oh, that's a lot. So sometimes we can talk about, I can use like orthopedic or neurosurgery response time as an example. So you have to track from the time that the orthopedic service or neurosurgery service was consulted until they got at the bedside. Well, if the time that the consult is not documented, but orthopedics doesn't show up for 3 hours, I don't know who to have those conversations with. Did we just not recognize that this patient had an emergent diagnosis and so we didn't consult orthopedics? Or we did and they just didn't respond in a timely manner. So having that documentation to help identify truly where your opportunities are is tremendous in helping you move forward and address your opportunities.
I like how you keep saying opportunities.
Very purposely.
Yes. Yes, I love it. What you got, Meredith?
Gosh, what is PI? I mean, I think I'm going to be real honest here. I think even trauma program managers and people who have been doing it for a long time constantly question, are we doing PI right? So PI is constantly evolving in the trauma world. It's constantly, evaluating your process and seeing if you can be better. It's almost like your own competition with with your own program. And as far as, an example of, strong or weak documentation that can change the course of PI, Ashley had already talked about some of the really big standards, such as emergent consult for ortho and neurosurgery, but we have to submit lots of different complications that occur in our patients to our quality improvement program from the ACS. And some of those are, was the patient unexpectedly intubated? Was the patient unexpectedly transferred back to the ICU? So I think for those kind of complications that we need to review and keep a pulse on, sometimes it's very difficult to understand the who, what, when, and where that patient had a status change. And so, if we can't find in the documentation from the nurse's standpoint what exactly happened in this patient's course, then we'll go to the physician documentation and we're like little detectives trying to find out what exactly happened with this patient. So when things are documented clearly as far as status changes, that can definitely change the course of a PI review on a patient's care.
And I just want to kind of add on to something Ashley said. I had the great benefit of our state medical director for trauma meeting with him one of my first or second weeks into a brand new program with no experience, no understanding of what PI was. And he told me he said two things. He said, a rising tide floats all boats. And it's a very old saying. You've probably heard it a bunch, but you will immediately see as you have success with PI that other people begin to want to borrow some of how you're doing things, but and it really does make a substantial difference across the board whenever you begin to see performance improvement really start to sink its teeth in. For me, I think another thing just with PIs, I try to constantly remind people that PI is not punitive. It is not something that's a case being reviewed or discussing a case. Historically, a lot of people have seen it as what did I screw up? And immediately, one of the first things someone wants to know is what did I do wrong? And many times we're just trying to get more information because something might not have been documented or something might have been competing documentation that doesn't lead you to understand exactly what's going on. And it's very obviously we can talk documentation all day. That's obviously a key part of not just care of the trauma patient, but care of any patient, understanding and having a clear picture of what's going on. And for me, one of the last things I'll kind of talk about PI, and I'll use an example, is a person versus process. And many times we'll review and see an opportunity, and if it happens multiple times, we look to see is, well, did different people have a problem? Because if it's more than one person, we probably need to take a look at ourselves and see if what process we have in place is actually being successful, or does what we're asking someone to do have flaws that need to be addressed more so than the people trying to perform it doing so. Now, if we have something that 99% of the people can do and it seems only one person continually comes back and doesn't meet expectations or we see opportunities, then maybe that's a different conversation to have. But for me, for the trauma nurses that are caring for it, please know that when questions are being asked or for reviews being going through, it's information gathering for us to disseminate and look forward to what do we need to put something forth to address it. Did actually what happened most importantly was the best thing to happen at that time. And for me, a recent case was just having the equipment available in the emergency department. There was a delay because of a piece of equipment that needed for one of our pediatric patients might not have been immediately available. And when we asked questions, we're like, well, I'm like, no, if the equipment wasn't available, we need to address that. And we just need you to let us know what we need to do to make sure it's addressed. Because if I don't know that something's not there, it's not your fault for it not happening. It's our fault for not having it available to you and making sure that everything's in place. So I'm not going to, documentation, of course, is always a huge thing to make sure that we're getting information, but just remember, PI is not punitive. If you intentionally hurt someone, maybe it will be, but that's not what we're looking for. We're most of the time just trying to get information so we can evaluate to see if there's opportunities for us to push to address and put forward to try to improve the outcomes of future similar patients.
So, Holly, you had talked earlier that this could be a huge conversation. PI in and of itself could be hours podcast. But when it comes to like our ACS verification and designation, PI and performance improvement is where a lot of centers have the most difficulty. And it's because we talk about the documentation that everybody else has to do. We have to do documentation on our end to show others. So we're not just telling other people you have to document. We have to document ourselves. And the big piece of that documentation is kind of talking to like what Jamin had mentioned, that you find an area that we have an opportunity for improvement. We identify an issue. We identify a trend. The data shows that maybe there is a system failure. We need a guideline to address that. So it's great that we identified it. So then what are you going to do about it? How are you going to get that piece of equipment in there? So you do something about the issue you identified, but then you have to show loop closure that you did put the equipment in, that everybody knows where that equipment is found, that you did develop a guideline, and then you run another report to show that you have stopped the trend. And so it is a big, huge, long process. And if you're studying for your TCRN, you'll hear about like primary and secondary and tertiary reviews. That's all part of the PI process of looking at how things are. And again, not punitive, but just how can we improve the system as a whole? And then making sure you document that, improve that you're doing what you actually say you're doing.
I almost couldn't believe we were going to get through this topic and no one say loop closure. I'm embarrassed that I didn't even
I was
say
actually
it.
trying to close the loop on this one and move on to the next one, but
It's like the
It's
number one
too
thing.
long
So
of a topic. It's
yeah,
too, you open up PI, like we should just have another podcast on it altogether.
it's great conversation, and it does segue right into the next topic, which really is talking about new trauma programs, and it certainly sounds like the number one answer to what I'm about to ask is have a robust PI process. But I will tell you a few of the things that I've heard is, there's a level one trauma center 3 miles away. Why do we need to even be a designated trauma center? If they're so close, why does it matter to our facility? Another one is we've had nurses that will say, well, we're a very rural facility and we're a critical access hospital. We transfer out just about every major thing anyway. So why do we need any designation? We send them to the designated places. So whether it's a level 4, level 3, level 2, level 1, if somebody's working to build a trauma program, and maybe we won't talk about the PI aspect of it, but they're wanting to focus on a few major priorities to help that become successful. I know it's very dependent on multiple factors, nearby facilities, geographic locations, many different things. But how can some TCRNs that do work in some of the rural facilities or smaller facilities that have a passion for trauma care and want to see their facility grow and become a designated trauma center, how can they really impact that at their facility? And then how can they also use some of their clinical background and some of the conversation they're hearing on this podcast to help develop some guidelines to even get started? So any thoughts on the building of a new trauma program and where some of those key focuses should lie? Meredith?
I think number one, if that's, these aren't exactly in order, I guess, but number one would be knowing the rules for your state, designation. I'm not sure if the scenario is ACS designation right away, but especially if you're working in a rural facility, you're likely a state going for state designation. So understanding your state trauma scene and the rules that will apply to the facility, and then administration buy-in. And one could argue you already have that if administration has decided they want to make a trauma center. But I mean, like, once you're identified as the point person to build this program or help build this program, you got to be real honest with administration and let them know the gaps in comparison to the rules. So, and then lastly, Jamin touched on this, is building relationships. Like, that's, when I took this role and was interviewing for the trauma program manager role, one of the things the trauma medical director told me, my task was to build relationships with inpatient nursing, OR, ICU leaders, because that really can make the difference between great trauma care and, you butting your head against the wall. So those would be my three priorities to start with as far as getting a new trauma program center off the ground.
Meredith, 100% agree with all three of yours. And just to piggyback a little more off the relationships, it's so important to understand the dynamics of your area, of your state, what does it mean to be a trauma program? What does it mean for a relationship with EMS? But even inside the walls of your facility, a lot of times you're dealing with other departments that have their own regulatory. So blood bank and lab. Part of building a program is to get a massive transfusion protocol, and to get blood availability is like a huge part of like the operations of a trauma center. But many times your blood bank and your lab have their own regulatory body that they have to live up to. And so you could write a beautiful that they may not be able to fulfill in a way because of regulations they have in place. So a relationship with blood bank, with your laboratory, with radiology, when you're talking about turnaround times, you need to sit down and not just say, here's what I have to do. You have to talk about it together and say, ACR may be may be the regulatory body for your radiology side. And obviously, most of the time, expectations will align where everyone's moving toward getting everything in the best of the patients. But you have to remember that relationship with the leader, wherever that is so important, because they have their own regulatory body many times that they are having to live up to, and things they have to submit, and you don't want to compete. And being able to sit down and have a 30-minute conversation with someone could save hours and hours, weeks of work if you're trying to put something in place. And so that relationship. And one other on the relationship side is one of the things about trauma program managers, trauma leaders, is they're so willing to share most oftentimes things that have worked for them. Whether it's a form, it's a guide, it's a practice guideline, it's something in place, and having someone who would, not saying that you're going to copy it directly, but it gives you an understanding of what's expected and a place to start so that you can then mold it to what would work best for you. So that relationship building in the walls of your hospital and outside the walls of your hospital, wherever it may be, is really important. And when you're starting something up from new, and you'll feel lost most of the time, like I did for a very long time.
I agree. Trauma is a team sport, and being able to call somebody and ask them to look at a case or an issue, if they know who I am and why, that it's not personal, it's, hey, is there an opportunity? Then we have the mutual respect, just that huge relationship and network. And the other piece is reach out to your professional organizations that are out there, just like Jamin said. So there are other people who have started without anything, from the scratch. So what helped them? What did they do that they would absolutely do again, or, oh my gosh, I did this, please don't do this, because it definitely helps the whole system. We have enough patients, we're not competing for patients, we're good. So how can we make sure that we help each other? So even just networking across the nation of other people who have been in those shoes is huge as well.
I love what each one of you said. One, because it all goes back to like relationship. But, my mom always said there's two ways to learn, either from your mistakes or someone else's. And so, as the second child, I feel like I had it really good because I got to learn a lot. Hopefully, my brother's listening to this. I learned a lot from you. Thank you. But learning a lot from, maybe what other people had a failure. And I think when it comes to learning from others' failures from your own, I would much rather see like, okay, hey, this is not the way to do it. We set out on this course and we had to back it up. And so maybe you should start from this point. And I think that sharing, that networking, that ability to have buy-in, because as you pointed out, Meredith, sometimes I think the embracing of a new designation or a new program, it's like super exciting when they're like, let's do it. But then when you start talking, like really digging into like what that might actually mean and how many changes and how many, logistically, like, hey, you're going to have to hire this many people and you're going to have to do things differently. And you're not like, when you start laying that out, I think sometimes leaders are like, well, we just thought that was not going to be this difficult. And so I think having that leadership buy-in and being able to have those honest conversations where you say like, look, this is actually a really great thing. Becoming trauma designated, whether you're state, whether you do it nationally, like it's a great thing because it means that patients who experience trauma are going to have a resource available that they did not have before. And so that's great. But the cost of that, both financially and just like time wise, like it's a huge investment. And so I think being able to have those honest conversations, keeping that excitement, keeping like the passion still there, that's a lot to ask. But I think you guys are doing obviously a great job and keep it up because we need more of you guys out there because there are going to be people who's going to be reaching out and asking like, hey, we're trying to get this going. What have y'all done? I'd like to learn from you. So I think that's fantastic. Thank you for joining us for the first half of this great conversation. Be sure to catch part 2, where we'll continue the Roundtable TCRN and dive into even more great discussion. You don't want to miss it. Look for the next episode dropping in 2 weeks. Until then, stay curious, stay connected, and we are out.